Good morning, everyone. Welcome to New York at Mount Sinai. I'm Karthik Guja. I'm the Assistant Director for the Mount Sinai Endovascular Program. Welcome here for the live case webcast, Endovascular Complex live case webcast for this month. Before we proceed on, the previous cases can be viewed on the archives of the peripheral-interventions.org website. You can go there, visit. Please let us know if you have any questions, and we'll be very happy to answer the questions. And the next live case webcast will be September 27th. You guys can mark on your calendars, and without any further ado, we will move to the lab to Dr. Krishnan's team and Dr. Kapoor's team. Dr. Krishnan, good morning. Dr. Kapoor, good morning.
Good morning. So we have a really fantastic case to talk to you guys about. Hope everybody had a wonderful end of July, early August. And we're well into our academic year, and we have Sandeep Singla as our new endovascular fellow who's doing a really phenomenal job. So we've got a great case here, which I think has an incredible amount of teaching points. So I'm going to have Sandeep go ahead and start in a second. But before that, I want to introduce our team. Obviously, next to me is Dr. Kapoor, and then we have Dr. Singla right next to him. We have Elizabeth in the back, Marichu, who's waking up, and we've got Damien, who's here. So I think that this is a great case. We're missing Ray. Big shout out to Ray. He's got a personal issue, and he's there, so we miss him here. And we're going to get started. Go ahead, Sandeep.
Okay. Good morning, everybody. So the case for today is a 83-year-old lady who has a history of known history of peripheral artery disease, diabetes, hypertension, dyslipidemia. She presented to us with the bilateral lower extremity claudication, Rutherford category 3, and right was more than left. Blood pressure is good. Pulse is 62 per minute. Next. On her labs, hemoglobin is 10.5, which has been her baseline for last at least 3 years. Platelets are good at 3010 K per microliter. INR is 1.1. Creatinine is good, 0.76. Her ABIs, which were done 2 months ago, 0.62 on the right and 0.88 on the left. Next. These are the images we took about 6 weeks ago. You can see the inflow, no significant disease on the right-hand side. Next. This is the occlusion of the SFA right at the ostium flush occlusion. You can see a stent there, and then going the flow into the profunda on the right side. Next. This is a cine run which shows the distal reconstitution in the distal SFA in the stented segment. Next. Below knee, there is a one vessel runoff. AT and PT are occluded. Next. And this is a foot angio, which essentially shows the peroneal reconstituting the DP and through collaterals flow into the PT also. Next. So the strategy we have for this case is, since we already tried an antegrade access 6 weeks ago, which because of the proximal cap anatomy did not work, we brought the patient back with an idea to do a retrograde direct SFA stick. So we're gonna do we already have a 7 French left common femoral artery access with a 45 centimeter up and over sheath. We're going to do a right distal SFA access through the stented segment. The idea would be a retrograde crossing followed by wire externalization, and then everything will be done in an antegrade approach. We'll pre-dilate. We'll use a filter because of single vessel runoff and a long occlusion. Atherectomy we'll see depending on how the lesion looks like. And the most important thing, which I have, we'll review some data on is what will be the definitive therapy for this patient. To start with, at least we have, we're going to use a drug-coated balloon or plus minus drug-eluting stents. Next. So, to summarize, we essentially have a case which is TAS2 type D, and by, Tosaka classification class 3 because of total occlusion. And then in addition, it has an unfavorable proximal cap. So these are the kind of the doable part, doability aspects of this lesion, which make it really challenging. And then the second question would be, once the lesion is crossed, what is the durability of the definitive therapy for this patient? You want me to keep on going, or?
Yeah, I think that's a good start there. Okay. I'm going to ask Vishal to go over our anatomy. We just did a quick review of the angiogram. As you saw, it was basically occluded SFA, single vessel runoff to the foot. And Vishal, why don't you go over what are some of the steps that we tried off camera?
As you can see, we got the angiographic assessment, and the proximal cap is unfavorable. There's no real peak. The stent is extending right at the ostium. It's like a flush occlusion. So like we do access, we again try to see if we are this time more, if we can get into proximally into the antegrade fashion and then work on it. So again, just to overview the distal reconstitution with the one vessel predominant peroneal flow. There it goes. So what we did is we went and up and over to the 7 French sheet. We have a microcatheter, which is an angled microcatheter we use here. And we started with an oven 4 confianza wire just to find a hub and a loop. So most of the time what we do is take the catheter down like PK did is, and we try to scrape the wall to see if you can feel a nub. Sometimes you're able to not see it but feel it, and by a tactile stimulation you could probably see the nub and try to poke it in, and this is what we're trying to do here. So if you can see our first shot, we're trying to poke. It's very hard, it's very calcified, it's occluded, and it's tending to going lateral. I'm going to show you another picture right there. So this is the first attempt. You can actually see our wire is behind the stent, and that's the biggest concern when you have ISR is getting behind the stent, because once you start behind the stent, the game is over. You have to find another route, another axis, another plane, or whatever it might be. So we went back again, same story. This time we were able to get into the so-called the lumen in the stent. We can see our wire here with the support catheter. But then our fine cross, the support catheter did not go through. So we changed it to a stiffer support catheter. That failed. And then they eventually went down to a coronary 2.0 long balloon. And here you can see even with the long balloon support, we're not able to crack open or pass any of our devices except the wire. So that's where we start thinking, what's our next best step? What can you do? Either be a little bit more aggressive, and probably PK will talk about it, doing laser and trying to open the proximal knob, or like Sandeep talked about, going retrograde access, either direct stick or perineal, but since the one vessel runoff, you probably go direct SFA stick. So I guess PK.
Yeah, I think it's a very fair discussion to be had. I mean, currently, right now, what are the options for this lady? I mean, she's a claudicant, symptomatic with pain. Second thing would be, well, in that stage, medical therapy, but we know medical therapy generally is not going to help a patient with single vessel runoff with significant claudication. And I don't honestly know how compliant she's going to be. I know her daughter, and we've spoken about her compliance with medications and things. And I can tell you that she's a great patient, but I think at this stage, very frustrated by this disease process. So second would be, okay, well, if that's the case, well, what about surgical therapy? Well, surgical therapy viable, although for claudication, probably not the standard of care as we speak, especially since it's only she's failed non-drug coated therapy at this stage, has not had the latest technology available. And third will be, if it is surgical therapy, what is the availability or the situation with her heart, and with the fact that she's a little elderly, what are the risks and the benefits in that situation? So I think it's reasonable to try another endovascular therapy, as long as that you're going to use drug as your predominant therapy, or your final therapy should be some sort of drug-coated drug delivery. Obviously, other challenges in this case is with single vessel runoff, and never mind the proximal cap that Vishal described so clearly, is what happens with if there's debris in this. Is there a chance of embolization? Can you convert this from critical limb, from claudication to critical limb, so on and so forth. So, there's a lot of things to be considered. Now, as far as the proximal cap is concerned, as you know, Karthik, Vishal described it beautifully. I mean, one of our hopes was to take this 2.0 coronary balloon, wedge it in, and make a little bit of a channel to go. The fine cross didn't go, which, as most of you know, is a transcollateral catheter for the coronaries. Are very slick, very easy to get through places. So there's a very calcified proximal cap. So for me, from my experience, when I look at this, I see a lot of different challenges. Well, one is access. We talked about direct access with the SFA, perineal access. Well, perineal, Vishal hit it on the head. Single vessel runoff, if you can do something different, you should. So proximal access, because of the cap, is prohibitory. So what about direct SFA access? Well, as you see, you have a long stent here. The stent starts from the ostium and comes all the way down, right? So there's our wire like we described. In the ostium, you follow it all the way down, you're going to see a needle at the level of the direct SFA. So the question is, what are the challenges? Well, one of the challenges is obviously patient positioning. So you see Damien and Liz have done a nice job. Our patient is very comfortable. We've got the leg frog-legged, and you can see the leg, how it's exposed and draped. If the camera can come over here, guys, just to show the team. Patient is very, very comfortable as we speak. We're also very comfortable in getting the access. Okay, that's one. Second is what are some of the thoughts of sticking the SFA? Well, ultrasound is possible. You can do ultrasound. Generally, we try to stick lower rather than higher. you know, and I think in this case we would like to stick the stent. The problem is there's flow within the stent. So I want everybody to understand that if you're not successful, you may end up bleeding from that stent. So obviously with the stent, is it compressible with an external device such as a blood pressure cuff? I'm not certain. So you know, the issue becomes is if you do get into the stent at the level of where the patient is bleeding, and now, where there's blood flow within the stent, and you fail crossing, and say whatever device that you put in, you're going to have to put in an 035 catheter at some point, or hopefully you get away with an 018. If you have to put an 035 and you pull this, you're not going to close. So and if you don't cross from above to balloon tamponade it, the patient may end up bleeding into the thigh, which again I think is going to be self-limiting, but you got to keep that in mind because the nerve, the femoral nerve, the vein all run right next to one another. You have to understand that aspect of what you're doing. It's just not sticking the SFA and being done with it. So what is your hemostasis strategy is something you got to think about. Then finally is after you get in, how are you going to get in, where are you going to stick, and where are you going to go? So in my opinion, Vishal and I talked about it, and just for demonstration purposes, we're going to give you a little bit of dye here. Vishal, can you hit a little dye? So you're going to see here that you're going to see that the patient has flow in this particular area. So I would like to stick up here, okay? Problem up here is the SFA is very deep, okay? So remember, the SFA is superficial, runs deep, becomes superficial again. Okay, so if you just think about it in that manner, proximally it's super. So then your answer could be, well, Prakash, why don't you stick up here? Well, if you stick up here, the problem is you may not have enough purchase. So you've got a lot of different challenges that you need to think about before you do this. So what we decided to do is, first of all, not anticoagulate. So we're not under anticoagulation 0. So we're watching, we're transduced our sheet, so therefore we know that if there's any dampening, she's forming clots, we're going to do frequent flushing of the sheet with saline to prevent you know, stasis and thrombus formation. Second, we're going to go with a small needle. We're going to go with an 035 needle here. I mean 018 needle here with an angled V18 wire. And third, we'll see whether we can reach a little more proximal. If we can't, we're going to have to go distal. So I'm going to pull this out.
PK, can I ask you a question? Is the wire going forward a little bit more from the proximal end? Because you're saying that you feel like you're in the stent proximally, right?
Yeah, I mean, we can definitely give it a shot here, Karthik. I agree with you. I mean, if it goes, it goes. Let's see. Give me an 018 Trailblazer here. Let's try a little bit more here.
I'm saying if the wire goes down, you're achieving the same thing as you're achieving with the
totally
direct
agree
axis,
with you,
right?
Karthik. But you'll see, with the fine cross, I know didn't cross. Question is whether we can go with a Trailblazer and then put a what is it called, a V18 wire in to give us more support. Let's see. I mean, one of the things Vishal did mention to me before we went live was, why don't we try the OV18 wire? And I said, let's see what you say. Straight trail. No, give me the angle trailblazer. So I can tell you that I think that's definitely a great suggestion, because the thing I want everybody to know is that everybody says, oh, let's stick the direct SFA stick. This is cool. That's cool. Remember, guys, it's all cool until you can't get hemostasis. This particular patient has got a stent. If you put a blood pressure cuff and you have blood flow within that stent, I don't know whether you're going to completely compress that stent.
That's right.
So you have to keep that in the back of your mind when you do these things. So, you know, it's not about sticking a stent. I mean, honestly, you know, my daughter can do this. The reality is that what are you going to do? What are the thought processes that you have to make sure that you don't create a problem for this particular patient? So, you know what, since you and Vishal both suggested this, I totally agree. It is something that, you know, I think it's reasonable to try. But I have a very good feeling that this is the 018 wire may not go just because this channel is so small. So let's see here. So here's Vishal's giving me a rail. We're just going to go down. I'm going to, watch the wire, please let the wire go a little bit. Thank you. And then I'm just going to get the wire, the catheter a little bit.
The only reason is the place where you're sticking, where there is no flow in the stent, it's a little bit too deep. And
hold on, let me give you purchase.
Yeah, give me purchase. Let me see if I can just sneak it in. Come on, baby, get in there.
No, hold on. Okay,
the other thing I can do is try to bring my catheter down. Show me above, guys. I'm going to try to bring my sheet down for a little more support. Let me see here. Nope, it's not going to go. Yeah,
let me give you more purchase.
There it is. All right. Well, I want everybody to know at home, Karthik is the party pooper. So now
No,
we're in.
I'm just,
So now we're in the stent. But you know what? It's a good technique to know. You know, I mean, it's a good technique.
the
Pull
question
out
is,
this
are
wire.
you, do you feel like you're within the stent? Does
Yeah.
it feel
I'm
like?
positive I'm within the stent
Okay.
because
All
Vishal
right.
made me look in 5 different directions earlier, and he was, as you know, Vishal is a detailed man, and clearly we're within the stent. So now the question becomes is, now we're truly within the stent ostally, and I think the angle trailblazer really made a difference here. Now what Vishal is going to try to do is try to get a curve with this next wire, which is the V18, and then we're going to go down, and then we're going to have Elizabeth.
No, I just I just wanted to get across that if possible.
Excellent.
Yeah, that's it. So
Okay, now hold on. Now Liz, you can give the heparin. I mean the Angiomax, or give me the Angiomax. So I think now it's going to go pretty easy, God willing, and it does. There it goes. Excellent. Okay, good. Show me above now.
So I just wanted to point out that, you know, I know PK was trying to see, PK is very experienced clearly in doing direct stent accesses, but if you're not very experienced in doing direct stent accesses, if you have some wiper, you have to try everything possible in your inventory to see if you can directly go through. Direct stent access is not like the safest way to do it if you're not experienced enough. Right, PK?
Yeah, you know, I think the points that we pointed out. I mean, Vishal and I think the clear issue is exactly what we talked about. Is you got to have an idea of hemostasis, right? Where is your hemostasis going to be? You know, and I think if you can't have good hemostasis, then you're going to get in trouble. Push forward, please.
The only place where you get the most amount of good hemostasis in a instant location in SFA
job,
is mainly at the level of the adductor
let's
canal
give a little down.
or the Hunter canal.
No, but you know what? You know, I'm telling you, you know, the more you do of this stuff,
Right.
you got to understand that that stent is incompressible.
Right.
So the area to stick is,
Right.
I'm going to just cine this, Vishal Gibson die. I want everybody to understand. In my opinion, you know, everybody will do what they want to do, but I mean, we consider at Sinai that we're one of the safest labs in the country, without a question, coronary-wise, and I think without a question, peripherally. We know our complication rates are low. Unfortunately, in the endovascular side, there's no parameters for me to tell you that with comparison to other labs, because it's not reported. But I know that Dr. Kapoor, myself, and Dr. Guja, you know, we do not have any complication, thank God. And the reason is because you have to think about everything that can happen 2 steps before you do it. So in my opinion, the place to stick this, and I'm just going to put my finger and have Vishal just give me a little contrast again. Give me a little contrast, V. So you can see the place to stick it is right here.
Right.
See, it's above
That's
that
exactly right.
collateral. So even if I fail, because remember, just because I'm in the stent doesn't mean I'm going to get through proximally. So now if I don't get through proximally, I have a hole in this artery where blood is now coming out into the thigh.
That's
now
right.
you could say, well, it's going to be self-limiting. If you've done a cut down of this, which we do in the Abbott Endomasters course, and we show everyone, is when you do a cut down of this, you'll see how close the nerve is running to the artery. So a little bit of a hematoma will create compression of the femoral nerve, and she can have a problem. So the issue here is not so much the hematoma causing compartment, because compartment in the thigh is relatively unheard of. The issue here is damage to the nerve and pain for the patient,
Right.
and discomfort. So I think here now, since we've solved the problem, we're going to go in, and we still have a lot of challenges ahead in this case, but let's let Vishal just push through. I just wanted to show that part here. So Vishal is trying, yeah, there you go. I hope we're not posterior.
Yeah, that's.
I don't think so. Pull out the wire and try to go straight now. Go. Try to push hard. You're getting somewhere. Let go of the wire. Take the wire out. Let me just push forward with this. No? Give me the Terumo, the other wire that Vishal likes.
Terumo Gold.
Gold. Yeah, there you go. Now go. No.
No.
No. V18 is not going. Again, you can see how fibrotic this is.
It's really fibrotic lesion.
Yep.
Yeah.
It's like otherwise normally it would just go through, right? It's like,
Also, what we can do, guys, is give us a Navi cross. Put this wire back, and
No,
we'll feed a Navi cross. So give me a new V18.
yeah, you can use an
So
035
the other
wire
thing we
to
can
cross
do is
no
now
PK.
go with an
It's probably
035
better.
system. We're going to put a V18 down, or you can put a, what is that, connect 250 or 200 wire, and then you can go down. But I think that's very important here. So now let's just get through, because obviously in this, I'll just show everybody why we're so confident. You can see in 2 different views, Vishal and I are clearly in the center of the stent. You see that? So, you know, I think I'm not worried about being outside the stent in this particular case. The other question is the connect, you know, in terms of wire choices, Karthik. What's your 018 go-to wire? First you, Karthik, then Vishal. What do you think?
Overnight, I usually use Connect. You know that I use more Connect than any other overnight wire. So
Right.
that's my go-to wire. If it doesn't then work, then I guess I think any if you fail with one overnight wire, I think any overnight wire is the same. Some people say V18 is better.
Give me that other
Same thing, but if the any overnight wire fails, I would just quickly switch to an 035 wire.
Look it up.
Especially in in-stent lesions like this, I think here you definitely need an 035 wire.
I totally agree with you.
Yeah.
I think we were kind of praying that we'd kind of sneak through. You know,
Because
Vishal is always likes to look
if
slick.
you are within the stent, there is no way you cannot cross. You will get into the true lumen
Oh, this is not
period.
035. You
I
want
need
035?
the-
Yeah, 035 catheter.
So I don't know, Vishal, what do you
You didn't
think?
go- you didn't go with,
Give me an 035
Navicross, guys?
please.
We don't have it?
No, we don't have an 035.
No, we did. We had it.
We have an
no,
018.
035 Navicross?
There it is. Right there.
Oh, there it is.
Vishal, what do you think?
No, I agree. I mean, I start like we started here with Confiance and then we upgrade. I usually like the V18. It's a very stiff, very supportive wire and it usually crosses
Yep.
almost everything. So,
I'm
It's-
surprised too that
but
it's not going.
yeah, it's very calcified and you're right. We need a little bit more support than the V18. So an 035 system with a loop should hopefully.
Now notice, guys, I'm not
us through.
asking Damien to unfrog leg her here, just because I think that we're not through this lesion yet.
That's right.
Once we're through this lesion, then maybe a different story. But at this stage, it's worthwhile to just be conservative, and let's see if this goes through. There it goes. Now we should be able to pop through, and now I know that we have no concern that we're within the stent.
Yeah,
Obviously.
definitely you are not
Okay,
posterior.
now we
PK.
can get the angle glide.
If the Navicross goes through, I don't think it's
Right.
posterior anymore. You are within the stent. So
Well, and the stent is not being deformed or pushed. So one of the things you can watch at is how the stent behaves. Say you're behind the stent or you're within the strut and
stiff
you're
angle
coming
glider.
down. A lot of times, actually, let's try the straight, Vishal, because we're
PK, now
gonna
you're
get into
trying
that
a
area.
straight. You
Let's try the
prefer to
straight.
try a straight glide or an angle
I
glide?
think in this situation, I would try a straight because we were getting into that little zone there. So I'm going to try to torque it away from that area and
Okay.
see whether we can find another little area, maybe on the opposite direction, where we can try to get in. See, it's rotating through here. Let me just keep it in that particular area and see
Okay.
whether we can just go. Yes, he just wants to go there. So let me try a different angle here. Again, the same problem. There
Yeah.
it goes.
There
Well,
you go.
I might be through a strut there, but we'll deal with it. I'm not too worried. Yeah,
No.
looks
No,
like
it's
it is
not
through a
distally.
strut, no, PK?
well, it looks like we're through the strut up
Yeah.
top.
So I would probably just
No,
pull.
we're still in the vessel. We're still in the vessel. So I think let's just go here. Let's deal with it and see what we get here. See, we're still in the vessel. Yeah, we're still in the vessel.
I think keep the loop the way it is and then
Yeah.
keep pushing.
Give me a little dive, Vishal.
Mm-hmm.
I think we should be getting flow here if we're in the right spot. No, not yet. Not quite
Almost
yet.
there.
Not quite yet.
So if you get the catheter down,
There.
Yeah, I'm just
Yeah.
trying to just kind of rake it through. There you go. Show me the other side.
I think you went
Yeah,
on
we're,
the.
no, we're outside
You
now.
were
See?
outside.
Okay.
Which is
Just
very
go down.
interesting. Let me see the other. Let me just go to another angle here.
PK, right where it went across, you think you went through a stent start right there
That
and
could
then
be.
came
That's
across?
what I'm a little concerned.
Yeah, if you pull
But-
back and redirect it at that spot, right there. So just pull back more.
Yeah.
No,
I
we'll
think
go
that's where
strut.
you're off.
See.
That's where you're off.
That's better
No,
right there.
Yeah. No, that's out.
That's
No,
out.
it's out.
Give me a new angle glide, guys.
New angle glide, stiff.
There it goes. Follow it now.
I think you're still off, right, PK?
Kind of like this, Karthik. I'm in the stand here, Vishal.
No, that's something.
Rail here for me,
Yeah,
buddy?
right there.
Okay, let's see. Now let's try to torque it the other way. So this is where a torqueable catheter may help you. There you go. I feel like I'm behind this trunk.
I think you're still behind the stent.
I agree here.
There.
So pull back to that spot and then probably redirect it.
See that? I don't know. That's a loop right there.
No, I'm right there though. See?
See? I don't
Let's come to the other view. No, in sopped up, we're okay.
Yeah.
ACT.
Yeah, we're okay. It's just a very fibrotic restenosis. Yeah, let's take that. I'm okay. Let's take incremental,
yeah.
incremental victories.
Yeah.
Okay, now show me down. A little down.
Yeah.
We're gonna be
Right at the
very
level
close.
of the stent overlap is where you form. So,
You just try to see if this flies.
Yeah,
so
well,
here, if you take your loop
Straight
off,
in.
PK.
Yeah, that's what I'm saying. You take the loop off and just
Take the
make it
loop off
straight
and try to
just go
poke it
boom.
in directly.
let's see. Let's just get a little bit closer.
here I would just straighten it
Yeah, let's just see.
and just poke it through.
Let's see if it just pops through now. We're definitely. Let me just torque. Go AP for me? Yeah.
Yeah.
So one of the tricks you can also do is now go AP and just torque it in AP. See? Like that. Now pull the wire out. Pull the wire out. Yep, we should be in. Okay. All right. Now that shows how difficult it really is to get into this vessel. Let's see if we're getting any blood.
I don't see any blood flow, right?
Well, we should. We'll get some. Give me a little syringe.
The direction of the catheter right at the
Give
the
us a
two
three
stents overlap is a little concerning.
Yeah, absolutely. It looks a little anterior.
Yeah.
Yeah, we're getting blood back. Give me a 5 cc syringe here. Let me just torque this a little.
Yeah.
There you go.
Do you want to give do you want to take a picture and see how?
Not
it
yet. I just want to withdraw blood first.
looks? No, not from here.
Yeah.
You want to give a dye and see?
Yeah,
where
we
your
might not
catheter
be
is?
across it. You're right. I
Yeah.
think we are though. I think we might just be in an occluded segment. The other thing we could do is try a 014 wire. Give me an 014. What is it called? Fielder wire, please.
There's a fielder.
Vishal, you want to just give a little bit
Yeah.
of dye and see where you
Yeah.
are?
Fielder wire.
It's coming.
Yeah, we're just in the occluded segment.
Yeah, the lumen is more central than what
Yep.
it is. We're just a little
We're
off.
just in a subintimal plane in the stenotic segment. That's all. Give me a shaper here. So right now,
So what kind of wire are you using, PK?
we're just using a fielder. I'm just trying to understand the behavior of this vessel at this stage. You could use a command as well if you'd like.
Vishal, would you do anything different?
I think any hydrophilic wire would be good here.
I would probably use a stiffer wire. I mean, he likes to find microchannels. I would probably end up use an overnight Terumo and see if it finds the.
Yeah, we've got that open too. Let me see here. Yeah, they're not behaving like we're
Yeah.
in a good spot.
I would probably pull back. There. There you go. Oh, I don't know. It's all the field.
Give me a little dye now.
I have a feeling it's behaving
Yeah.
as if it's like behind the stent. So
I'll probably pull back.
I'm shocked though. If it's
It
behind
doesn't
this,
look behind. I mean,
give
I
me a
don't know, we can-
Terumo 018 Terumo.
No, this is
035.
Oh no, this
This
is
is
an
035.
035. Sorry. Give me 1 second.
PK, what stent is this? Again, I'm sorry.
This is just an
Give me
Everflex,
a,
old Everflex stent.
Okay.
Terumo. Yeah, give me one. Yeah, that is gone.
I'm surprised.
Yeah, me too. Give me a little dye here. Let's see.
Yeah.
Flash more.
No, another thing you could do is just go with a 035 supercore wire, because what that'll do is that'll prevent you from going anywhere you don't want to go,
Okay.
and just try to just get in. Let me just pull this back here a little bit.
It's gone.
Yeah, I would probably pull back and try to find a torque.
So, but this one, show me down, bro.
Mm-hmm.
That's good. I got a loop now. Okay, show me. Give me a little dye now. Let's do a roadmap here. Inject.
Injecting.
I see the loop is too big. I just think you're going to keep dissecting down.
Yeah, I would just
See, it should just go smooth.
probably pull
At
back
this
and
stage.
find a new channel.
Yep. There he goes.
There.
Now you're in.
See?
Okay, good. So now what we're going to do is try to track this down.
1 second. Off photo.
Yep.
Okay.
So you had you're clearly in the lumen, PK.
Yeah, now
right?
we
So
are.
You're clearly in the lumen.
Now what we're going
So
to do
you're
is
saying
try
that you
to
just
track
found an
this.
eccentric channel.
Pull the
That's
wire
why it
up.
is
Yeah.
like that.
Actually, just leave it there. Just show me the wire. Just watch the wire.
Yeah. Hold on.
If not, you can always use a 4O balloon, right? Create your tract.
We could, but I prefer to get this down if I can.
Because it looks like you're definitely going to use an atherectomy device here, right?
I don't know. I mean, that's one of the things I want to
It's
talk
fi-
about.
it's
once we get this
fibrotic
baby
and then-
down.
Looks like it's tracking pretty okay.
I'm worried about my sheath up top.
Yeah.
And rightfully so.
You want me to hold
No,
it?
I'll do it.
No, no.
Oh, well. Thank you.
PK, you had your breakfast, I can see. So
Unfortunately, Vishal and I were talking about it. We want the audience to put up a collection to get you a tie.
So I just want the audience to know I'm always with a tie.
Show me high.
I was just told that there's no live case today. This is a surprise to me. If I knew there was a live
Show
case,
me
I would
down
have worn
below.
a tie.
It was actually Vishal's idea.
Wednesday morning surprise test.
Whoa, watch it.
No, just go.
So I want everybody else to know throughout the world that I get surprises all the time, that there's a live case.
Okay. A little more. I think we're good here. A little lower.
I think you're good there, PK.
I agree, bro. I just want to get as much. Okay, now pull it out.
That
Yep.
feels a bit better.
Okay, now give me an 035 Supercore.
I think you should see a lot of
Well,
blood
actually,
flow
now we should decide what's our therapy going to be. Let's check our position here.
Contrast.
Well, the question is, okay, now let's talk. Now we're across this. You've got good blood flow. Vishal is going to give a little test. We'll draw back, make sure we don't have any clots before we give it. DSA, please.
Are you expecting any clots, PK?
I don't know. I think we've been surprised multiple times with things that you don't like to see, and I think it's better off to just make sure by withdrawing some blood back within your catheter before you give dye. I actually had a case last week, Elizabeth will tell you, where we actually just injected thrombus down from this situation. All right, good.
Looks
So
good.
now we're here. But as per our algorithm that we all created, we're going to put a filter down. So give me a 4.7 Navicross, which is off-label for this purpose. Now, Vishal, Karthik, what do you guys think? What would you do in this case? Would you do?
I would go ahead and do atherectomy. I mean, there's so much fibrosis.
So laser would be something.
Laser would be my choice.
Karthik?
What do you think, Karthik?
I would definitely put a filter. There is no doubt about that, and I would definitely put an embouchure filter because it's definitely going to move.
Right.
Because of the whole thing.
All right. So I think we all agreed on the filter. We'll put
the options here. The options here are laser. I would prefer laser also.
All right.
But you can always. It's so fibrotic. You can always use any atherectomy device here. I don't think. I understand laser is used when you think like you have a mixed tissue, fibrotic tissue, and a clot, which probably could be the component here. But I think you can go any atherectomy device here and you can achieve the.
I think it's I want to focus a little bit, and I've asked Sandeep to prepare on this topic a little bit and to enlighten all of us. Sandeep, in terms of the data, what does the data tell us we should be doing in this case?
So I have a couple of slides. This was actually SFA restenosis. As Dr. Krishnan mentioned, actually represents the Achilles heel of the peripheral intervention. And over the last 4 to 5 years, multiple things have been tried to address it. So what I did was, we kind of looked at the most recent practiced modalities and what is the supporting data for each. So I can go over that data if you're ready.
Yep, go ahead. This is a great time.
So just as a background, for the audience to understand, that FemPop segment behaves differently as compared to carotid, coronaries, and iliacs. Multiple reasons. One, it's the longest vessel, and it is exposed to extreme forces which predispose this vessel for restenosis, in addition to its biological reasons and other factors which are not well understood. Next. So there was Tosaka et al. Made an effort to systematically study the restenosis in SFA segment and how does it impact the outcomes of intervention in SFA restenosis. So they classified into 3 classes, class 1, class 2, and class 3. Class 3 was the occlusions, and class 1 and class 2 were divided into 2 groups, less than 50 millimeter restenosis and more than 50 millimeter restenosis. And next. What they showed was that if you intervene on restenotic occlusions, and if it was 100% occlusion, even with re-intervention with the angioplasty, the results are not the best. As you can see, The 3-year patency rates are very dismal, close to 20%. Next. More recently, we have, the biggest limitation of TSACA classification was that it only addressed in-stent restenosis. It did not address a restenosis resulting from, contemporary therapies like atherectomy or atherectomy in combination with the drug-coated balloons or DCBs alone. Next. So what they did was we have 5 groups. Group A and B address the focal lesions, where group 1 is unifocal and group B is multifocal. Next. Group C and group D are more diffuse disease but without occlusions, and group E is the occlusions, which can be of any length. Now we don't have data that how does this classification predict clinical outcomes. That data should be forthcoming in the future. Next. And coming back to the question of what is the most challenging part of the procedure, Dr. Krishnan and Dr. Kapoor, they addressed now live. They were able to get across this long occlusion with a very difficult cap anatomy and a very fibrotic lesion. Now the question arises: what do we offer this patient as a definitive therapy? There is a recent review in Journal of Vascular Surgery which kind of lays it out. Next. So reading through this and reviewing the recent literature over the last couple of years, what we strategized for this patient was we had these options. The first is drug-coated balloons, then drug-eluting stents. Number 3, as Dr. Vishal and Dr. Kapoor and Dr. Guja were discussing, they talked about laser. We'll go over some data on that. Then what about stent graft? And then the upcoming therapy of brachytherapy, and always an option is a surgical bypass. So we'll go over each of this. I'll kind of one trial each for this. Next. So the most relevant data, to our patient, this is a diabetic patient who's 83-year-old. I can relate to, or if I have to choose, dig the data is from the DEBATE-ISR. This was a prospective all-comer study where they looked at, the risk of what happens to reintervention in diabetic patients who have in-stent restenosis. So next. As you can see, the 12-month data was very looked promising. There was a 86% freedom from TLR. Next. But as you look at the fine print, the TSACA 3 class 3 lesions, which actually our patient would be, the odds of the patient having a recurrent restenosis is 4.8 as compared to restenosis. Next. And more sobering is the data, the 36-month data from the DEBATE-ISR, which shows there is actually an exponential fall in patency between 12 to 24 months. It essentially falls from 85% to close to 60%. Next.
So basically, you went over what? You went over DEBATE-ISR.
DEBATE-ISR, and so then
So DEBATE-ISR studied what?
They studied diabetic patients with SFA restenosis.
Yeah,
and they looked at
what
PTA.
What did they use?
PTA.
They used PTA.
Yeah.
So it was angioplasty?
No, drug-coated balloon.
Drug-coated balloon. So
balloon,
I think it's important for you to,
balloon.
when you do this, to actually talk about what was studied in the trial.
Yeah, drug-coated balloon.
So drug-coated balloon versus what? Or was it a registry? Was it randomized?
It was not randomized, prospective single arm.
So that's what you need to say that.
Yeah.
So this way everybody can get it.
Okay.
So that's important. So go back a couple of slides, guys. It's okay, leave it there. We'll just drop it off in the front.
Back, one back. Yeah. So it was a prospective all-comers, and they have historical cohort was the comparison arm was the diabetic patients.
Okay.
And they used paclitaxel eluting balloons as the treatment arm.
Okay.
And then after that intervention for the SFA restenosis, they looked at the outcomes, 12-month outcomes.
Got it.
And they classified by TSACA class. Right. Next. So as Dr. Krishnan mentioned, so basically, you can see 85% patency at 12 months. Next.
And how was that patency derived? Was it Kaplan-Meier, PSVR?
It's a Kaplan-Meier.
But was it a PSVR ratio? Or was it a? What was
that
the?
I have to look at.
Yeah, I think that's important. I think for the audience, when they look at it, they got to understand whether you used a PSVR or what was your definition of patency in this particular study.
Okay, I didn't address that in this presentation. No.
Yeah, I think that's important.
Okay.
Okay,
next.
Keep going.
But at 36 months, we talked about it. Next.
This is where we're going.
And similar,
There it
data
is.
from
Send it up.
Impact Global ISR.
That's good, that's good.
This was Impact balloon.
good
Similar patient subset where the occlusions were about 34%. We only have 12-month data, and the patency was again close to 85%. Again, I don't have further data like how did they define patency and how did they define freedom from target lesion revascularization.
but I mean, just
Yeah,
for
for
the just
future,
for the
yeah.
audience, obviously, you want to compare apples to apples, right? Or you want to understand what was the definition of patency.
Okay.
So obviously, patency is different than clinically driven TLR, so on and so forth. So I think, and also different trials use different markers of patency. So whether it's a registry or not is different. All right,
Okay.
go ahead, keep going.
Yeah. Next.
All right,
So
you-
in the
you can
second
straighten the
therapy
leg out.
we wanted to consider for this patient is now you have to understand with drug-coated balloons we may get the results, but there is always a risk of recoil and dissections. So drug-coated balloons as a standalone therapy may work if we have good flow without dissections, without recoil, but not uncommonly we end up requiring stents. So to address that, we can the second option we considered was drug-coated stents, which we had as Zilver PTX. There is data from the Zilver PTX registry. Next. It was they studied basically in-stent restenosis patients, and what they showed was that the 1 year primary patency was close to 80%, and
Take this off.
freedom from target lesion revascularization at 1 year was 81%, and which dropped to about 60% at 2 years, which is similar to data from the drug-coated balloon at 2 years. We don't have data, further data like 3-year or 4-year data for Zilver PTX registry. Next. So as Dr. Krishnan and Dr. Kapoor mentioned, the question of using laser. This has been addressed in in-stent restenosis of SFA in the Excite ISR trial. They had the primary patency with this approach was 71% as compared to PTA only, which was 56%. An interesting finding in this was that as the lesion length increased, the efficacy of laser, combining laser with PTA increased. But again, this is only a 12-month data, and when we compare this, 71% primary patency to Zilver and DCB, DCB and Zilver still outperform laser in combination with PTA alone. Next. Now, what about stent grafts? We know the stent graft would definitely address the issue of restenosis within the segment of the SFA other than the edge restenosis. This was looked at in the Reline trial.
Liz, flush.
Next. And we had in comparison to PTA alone, Viaban had a primary patency at 12 months of 75%.
No.
We don't have a long-term data, but the biggest issue with using stent grafts is the risk of the need for long-term anticoagulation, and second is the risk of thrombosis. Next.
Oh, okay, it's open now.
Now, other therapies like a standalone PTA with cutting balloon, or standalone directional atherectomy have been looked at for ISR, and but the patency at 24 months is dismal. It's, in all these, it's less than 50%. As you can see, highlighted in red, it's 48%, 15%, and 49%. Now, I did highlight PTA and brachytherapy in green. We'll talk about it. This may be the upcoming therapy to address this challenging subset of patients. Next. So a recent publication where they looked at how does high-dose brachytherapy with a close surveillance perform in these patients with SFA restenosis. Next. Excellent 1 and 2 year patency, as you can see highlighted in yellow. The primary patency at 1 year was 75%. And 63% at 2 years, which is similar to our DCB and Zilver PTX studies. But the biggest challenge or the biggest issue would be, there were quite a few cases of early and late thrombotic occlusions, and this is similar to what we see clinically, brachytherapy being used in coronaries. But the good thing is we are not leaving any hardware in the vessel. And if the vessel needs to be re-intervened in future, this may become as one therapy which can provide patency for at least in the interim. Next. Now, surgical bypass is always an option, but this is an interesting data which shows that if you do surgical bypass in patients who had a percutaneous intervention done prior to surgical bypass, the bypass tends to do worse in terms of patency. And this may reflect the patient's underlying predisposition to restenosis or atherosclerosis. Next. That's it. And as we said, in this patient, we're gonna be definitely choosing a therapy between something based on the drug, either a drug-coated balloon, and if there is evidence of significant recoil or dissection, we'll go with the drug-coated stents.
Yeah, I think as the data is very challenging to understand. I think clearly, there's three things. Is the options are very simple. If you break it down, your option is plain old balloon angioplasty, laser atherectomy, drug-coated balloon angioplasty, or you're going to go with what is it called, a drug-coated stents, or you can do covered stents. So I think these are your options. So if you look at the data head-to-head, there's zero randomized control data, zero. So you have nothing saying that drug-coated balloon is better than drug-coated stent is better than anything. You just have registry data all along the board, with the exception of the DEBATE-ISR study, which is a randomized control study that randomized laser with balloon versus balloon angioplasty alone. Obviously, the 12-month data with DEBATE, as went over by Sandeep, is not exciting. So therefore, we need to figure out on what we can do. So I think as interventional cardiologists and radiologists and vascular surgeons, we go ahead and do a combination therapy into what we think is best. I think the need is there for some sort of atherectomy, possibly laser atherectomy, because of its photoablative capability of burning away debris as well as thrombus in this. Not so much in terms of my luminal gain, because I don't know if I'm going to get a lot of luminal gain with the laser. Directional atherectomy, I think there is no data to support it in terms of it's got an IFU contraindication in ISR. And I think, honestly, directional atherectomy in this particular case is going to be very tedious and cumbersome without possibly giving me the results that I need. Although we're looking at our data of atherectomizing to less than 30% residual restenosis, which seems to look favorable, but takes a long time in order to achieve that in such a long stent. Third is the drug-coated balloon. Drug-coated balloon is nice because you treat it with a biologic reason for the restenosis. So if you look at a thrombotic reason for the restenosis, then you would do lytics followed by a possible covered stent. If you see a mechanical cause of the restenosis, possibly a fracture of this, maybe you treat it with a covered stent or a supera inside the stent. If you look at a biologic cause, which is likely what this is, which is intimal hyperplasia, maybe a biologic therapy should be your final therapy. And I think if you keep that algorithm in your mind as to what you think caused the restenosis and base your therapy based on that, I think that's what Vishal and I know we always do, is we look at what we think it is. Clearly, the amount of fibrosis and restenosis while we crossed this clearly showed a biologic cause. Possibly a thrombotic component is always there, and I think that's why we're using the filter and that's why we're using the laser. But I think here the definitive therapy has to be biologic. As far as covered stent therapy, it kind of covers both. It covers the biologic side of it because you can put a covered stent and you can exclude the ingrowth of the plaque. However, here you have a lot of global atherosclerosis. You have inflow disease, you have outflow disease. I don't want to compromise any collaterals in this particular case. As you saw, there was mid-SFA collaterals that actually kept the stent open distal. So I think that in this case, I would like not to use a covered stent if I can help it. Vishal, you want to talk a little bit? Or Karthik, why don't you give us your thoughts as we start lasing here. So we're going to go lase. We're going to go at
so I think,
30-60.
As you said, everything was right, PK. I mean, that's exactly what the data shows, right? The EXCITE trial is not very exciting, as you said. It says it still doesn't show the data enough to do it. So I think even for in-stent restenosis, even if you don't atherectomize, if you do DCB or if you use drug-coated stents, I think you can get the same amount of data. But again, the patency rates are so low that I think combining therapies I think might be the way to go. And I think there is no data on it, but I think anecdotally you can say that combining data might help. I think future studies need to be done. Vishal.
No, I agree with you. I mean, it's all about what's the underlying pathology of what's causing ISR, which we all know is a component of both thrombosis and neofibrosis happening. So I guess
60-60?
I guess it's the approach, and like PK correctly said, saving those collaterals, which is our primary goal in case for some reason our second line of therapy also fails. At least we know the collaterals are patent and the patient is going to be a chronic limb and not an acute limb. So in this case, I would probably stay away from the covered stent, even though the data was supportive in a way or better than regular PTA. My personal experience, I would probably end up with a drug-coated technology to get that anti-proliferative effect and see how the patient does. If the patient comes back again with similar problems, then we have to start thinking a strategy that, okay, maybe it's time to get the surgeons involved and see if the bypass is the long-term patency. And again, with bypass, you have to figure out is it a vein graft or a PTFE and all those factors. So it's like PK addressed, it's a very complex decision, both from a technical aspect and from a treatment aspect. So we need to keep everything in consideration. So it's a great case to discuss, do, and talk about. So now you can see like PK is doing the laser very slow. Take your time, because all these things, because the whole idea of the laser is the energy generation. If you quickly pass through, then it defeats the whole purpose of doing an atherectomy, especially a laser atherectomy. So you can see PK, he's being very patient, which is
45,
which Karthik is very unusual, but it's a live case, so he has to behave.
He's getting older, so he's getting more patient, so it's okay.
So he's getting older and slower. That's why he's patient.
Yeah.
Yeah, absolutely.
So
I didn't say that, but we are live.
So PK and Vishal, I want to ask you a question. So we had tough time getting through the proximal cap. So we go to DCB. I agree with both you guys that you have to preserve the collaterals. You want to DCB, and we went in different directions. So we're not going to have a concentric path for this. So the DCB is fine. It's going to cause neovascularization, but we had difficulty with the proximal end. PK and Vishal, do you think you want to put a silver only at the proximal end, just to cover the ostium?
Yeah, I think that's a great idea. I would probably, you're right, I would probably PTA, DCB and see how it looks. And I think it all started from the inflow is probably what caused all these issues. So that would not be a bad idea at all to put in a silver layer over it for long-term patency and hoping that it stays. So I'm definitely open to that option, and personally it should work.
PK, what do you think?
Well, again, being older, a lot more gray than the both of you, to me, you're not going to know what your definitive therapy is till you balloon this out.
Yeah.
Till you balloon this. I don't want to go into that area where there's flow. I think we got a good lays here. I think you got to balloon this.
So
the balloon is going to teach
PK,
you.
just for the sake of audience, you went 45, 45, then you went 60, 60?
Yeah, Vishal is right. I think, I tend to be a little bit more aggressive with my rate and fluency. I don't think there's any reason to go that high. I think that, I think 30, what did you say, 30, 60?
Well, it started with 30, 60, and then we went up because we realized.
I mean, there was a little bit of resistance in going down.
Okay.
Increase our fluency.
Okay. So we're going to do a DSA picture now. I think we're done with laser. Let me just give me a DSA shot.
Yeah.
So you went 60, 60 only because you had resistance and you thought you needed more.
I had resistance in that middle area, and I think there was a little more fibrosis in crossing it. Let's just do, and one of the things I like to do is go distal to proximal with my angio just to see clot if it does go down. Ready to inject? Okay. All right, nice flow.
So that looks like it's pretty good.
See, there's a little issue there where we had trouble, but that's okay. So now I think ballooning it is going to tell us. So I want I'm going to go with an 018 balloon here. Give me a 60.
PK, do you want to take a picture of the proximal segment also and see what's happening?
Yeah, to build on what you guys are saying, I think you got to be very careful in this segment. I think in this segment you've got a very diseased common femoral with profunda that's very, very closely involved. I think you got to be very careful. Let's see how this artery behaves with a balloon. One of the overkill things that people generally do is a cutting balloon. I think if you lased it, you generally have a pretty good release of the fibrosis, and I think you can do it with a general balloon angioplasty. I think cutting balloon, if you have drug-coated cutting balloon like the chocolate bar study, if that shows some effect, I think that may be something we could use in ISR especially. But I think here we'll just go with a regular balloon. Can you give me a non-DSA?
So you're taking now a regular non-compliant balloon, or you were taking?
Well, we just go with a compliant balloon because I don't believe a non-compliant balloon will cross this.
Okay.
I mean, the only non-compliant balloon we have in the lab is a Dorado, and I don't think the Dorado is going to cross. So I think we're going to go now very gently here into.
Why are you not directly going with a drug-coated balloon, PK?
You know, I don't know if it's going to cross. Honestly, I just want to see because.
But your Navicross crossed, right?
Yeah, I mean.
Your Navicross crossed, and your laser, the laser you used was what? What size laser?
A 2-3.
So 2-3 crossed. So I don't see a reason why.
No, I guess you're right, but I guess my issue is we usually want to use drug-coated balloon more for delivering the drug rather than doing a PTA. So using a more stiffer balloon ideally would work great in this case. So just expand the vessel, like you said, see how it behaves, and then do a DCB.
Okay.
I know it's an extra step, but
no, what I'm saying is normally,
a lot of extra stuff.
PK, we were traditionally taught that the more you balloon the in-stent, the more thrombotic mechanism you're going to create, right?
Well, there's no question, but I think here we were all over the place when we crossed, and I think it wasn't like a straight down the middle kind of easy cross. So I want to balloon this. My gut is telling me to balloon this.
No, just for the
So
sake
I'm
of
gonna
audience,
balloon this
I
really
just
high.
wanted to know, okay.
Okay.
Yeah.
So chest pain. Okay, down.
Looks like the expansion is great.
Well,
except
that one area is not
except
that
that
great.
one area where
Yeah.
we
Where it just
re-entered or.
turn around.
Watch the filter. It's going to be full. Keep coming back. I'll tell you when to stop.
CK, PK, your idea of covered stents. I know you don't shy away from putting covered stents in in-stent. What is your experience on it?
Well, I think runoff matters. I think you have to have, 2 vessel or minimum or more runoff. See, in this case, you can see it's just so unfavorable, the amount of restenosis that this young lady has, that you're really going to have to go with a better balloon to really prep this and do this. She's already having a lot of pain.
7.
So go to 8, 9, 10. So, you have to be aggressively ballooning, and that's why you have great nursing like Elizabeth and great teching like Damien to really help you. Go to 12. You really have to be a little aggressive.
That spot at 21 again is a concern, right?
Yeah, well, that's all the plaque down.
That's all the plaque on one side, eccentric plaque, no?
Yeah, it's all eccentric. That's why we had a lot of trouble crossing. And part of having the filter down is, like you said, we can easily be embolizing as soon as we inject. So we'll see. So Vishal is going to just come up.
Okay, those areas where you have eccentric expansion of the balloon, would you go back and re-atherectomize them?
I don't know. I mean, let's take a look. Come up a little more. We're going to come up a little bit more. We're going to have to come into the common femoral a little bit.
Maybe right there.
Right there. Yeah, I like that.
We can pull back more.
Yeah. I just came back a little bit more.
You pulled.
Yeah, I think that's reasonable.
I think you gotta, make an effort here to open this properly. And you can see that, it was difficult to get in because it was a very eccentric entry into the stent.
Yeah.
And you can see the amount of eccentric plaque here. And you can see as we expand it, Vishal is going to continue to expand it. There's all that eccentric plaque at the ostium. 14, 16.
Like I know laser now came up
Yeah,
with the
don't touch
directional
that.
laser catheter, right?
Yep. Okay. Down. All right. I mean, I think we did a pretty good job of ballooning. Our filter is still pretty stable at 15 where I left it.
No, PK.
Yep.
Laser now has a directional laser atherectomy device,
Yeah.
right?
Yeah, we talked about it, Vishal and I. I think at this stage we wanted to just get rid of the debris.
Okay.
I think the biologic effect of laser and ISR is really overrated. As you saw with the Excite trial, I think in this particular case you're going to need definitive therapy with a drug. And
No,
I think
I'm saying because of the amount of eccentric plaque built up, would
Right.
you use a directional atherectomy right at the ostium and that 21 point so that you can get more concentric expansion of the drug-coated balloon?
I agree with you in some respects, but the problem is if you start looking at the data carefully, there's really no benefit, DSA. Actually, no DSA, it's just inject.
Yeah.
There's really no benefit to having additional directional atherectomy in this particular case. So you can see there's our filter. We have good flow.
Beautiful.
Now we're going to do DSA to look at the stents.
Okay.
Is she okay, Liz? Okay. So let's just look at the. So I think at this stage, I'm not going to open another device at this stage. The question is, it's more about what balloon we're going to use for the mid-distal, and then whether we go with an 035 Dorado first, and then we go with the balloon after that.
Okay.
Wow.
Perf. All right, guys. No, it's an AV fistula.
No, it's an AV
It's an AV fistula. It's an AV fistula. No, it's a perf.
It's a perf.
Yeah. Looks like it. All right, give me a Dorado. Give me a Dorado. 6-0. So you can imagine that just with a regular balloon, we have a
Perf, and
small
what happens when you
perforation.
get a direct access into the stent? So you're just going to leave the balloon
I'm
compression?
just going to leave the balloon for a
It'll be fine.
second. I mean, you expect this to happen.
Right.
You're going under high pressures. It's contained, as you can see. It's not expanding,
Right.
so I'm not too worried.
It's
I
probably
still think this may be an AV fistula.
Yeah,
No,
no,
it's behaving more like a perf now.
It's not going to go away.
Yep.
Yeah, usually should.
Let's go, guys.
she has pain, PK, or
No pain.
no pain? Okay.
But remember, this is where the neurovascular bundle is, like I told everybody.
Flush it.
But it's an odd spot to get a perf.
It's
Yeah,
a very
it's
odd
just-
spot, I agree.
Yeah. Especially after you cross the CTO.
Mm-hmm.
Th-
Question is, did the wire go out and then we got into this issue?
Yeah, it's possible. And also, I don't know if it's so eccentric that that area you didn't atherectomize, remember?
Let me go
Just
up
go
there.
there.
You didn't go
What
down to
size
that area to
balloon is this?
atherectomize.
Go forward.
Yep.
Go.
So PK, now what would you do if you don't contain the just covered stent?
You're going to have to. But I think, like I said,
I think that
that's-
spot is a spot, no? That's a
Well,
spot.
the runoff is there. We got to
1
make
second,
sure.
off floor.
I got to talk to her daughter about, the compliance with the medications, especially if we put a covered stent in.
I would just keep it. I think it'll be fine. Fine.
Does it hurt when I press? Nope, she's fine. It's very contained.
Good.
It is very contained. You can see it. So it's
7.
the question is that one spot is concerning. The amount of
Well, it's interesting because if you look at the stent in that one spot, you
Yeah.
see how it's eccentrically expanded?
yeah.
So I think that's where the perf is. Ready to take a picture?
Yeah.
Inject?
Inject.
Unless the collaterals are still feeding it. That's
I doubt it.
yeah.
I think it's complete. Should be completely occluded.
Can I see this? DSA?
You.
Okay,
I think it's good.
very
It
good.
just-
So now
I think
we
it'll
got
be fine.
complete seal of this. Now the question is we just need to figure out whether you use a covered stent in the distal and just do or just leave it with just a drug-coated balloon. So let's put a timer on for 5
That's
minutes.
Right there. 1 minute already.
Show me the picture of the perforation.
PK, if you have to put a covered stent, right? Assuming,
Minus-
would you cover that area of eccentric expansion, the whole thing?
I don't know. I'm just thinking to myself
I would
that,
probably
like,
want
can
to
I
leave
get
it.
away without? No, it's below. It's below. You see
Yeah,
that? See how it's below?
it's the area where you didn't
Where we had to
atherectomize,
toggle.
neither you did anything. I think it's just because of the ballooning.
Yeah, but let me show me the balloon expansion in that area. Well, it's funny because she had a little bit of pain, but I mean, you would expect that with. Oh, we didn't see any of the balloon. You would expect that with any sort of what is it called, angioplasty that you do.
That's right.
So it wasn't anything outside the ordinary here for us. So I think at this stage, what I would do is I would just leave the balloon up for 5 minutes.
I think it'll go.
I will take a picture, and then if I can avoid putting a covered stent, I probably would. But obviously, we need to do an ultrasound before she goes home tomorrow. But let's see how it looks. Let's see how it looks when we do this, and let's see. We've turned off our angiomax for the time being. The ACT was high, which we wanted. The blood pressure is a little higher. Oh, she's going to the bathroom. Okay, that makes sense. Okay, good. So far, so good. I think that this is some of the things that the audience has to understand that we are going to have in these complex cases. So the question is, how do you handle it? And I think here the covered stent would be my last option, just because of the runoff. I prefer not to. But if I did a covered stent, then I would probably do that initially, then do drug-coated balloon distally and proximally, just to make sure that covered stent doesn't go down. That's all.
Okay.
So let's see how it does. So we're at 1 minute and 32 seconds here.
No, 2 and 45.
Vishal, I don't know if you observed or not. PK keeps taking the support of the table all the time. So I just wanted to
Support of what?
the table.
Oh yeah.
So over the years, if you see, like he used to stand up. Now
I
he's
can't
going
stand
back
up
and sitting
anymore.
on the table.
I'm going to be one of those guys sitting down and doing angioplasty, I think, But I think at this stage, I'm trying to think of how this, why this perforation occurred. I'm thinking that possibly the wire was not really that subintimal in that area.
We didn't go we didn't go subintimal in that lower down in
No,
that
we
spot,
did
no.
not.
So it's unless you had a totally eccentric expansion, it's possible. And
I think that's what probably happened, is just an eccentric expansion. It just popped through it.
All right, guys, let's, in the meantime, I think it's important we get the covered stent. So give me a 7080 covered stent. And a 70, I think 708 is available, covered stent.
I think it'll work.
50, there should be an 80 there. Oh, 75, yeah. That's fine. So we just cover that small area, we should be fine. Don't open it. So this is part of the thing, right? When I think this is a great thing to talk about with the audience as well, is when, you know, what are the equipment that you need to have in your lab? I mean, Karthik, you run a very busy OBL in New York. What are some of the equipment that you have in your lab? And then we'll talk to Vishal. I know he's now the director at St. Luke's. What are some of the equipment that you guys both like to have in your lab?
So for my OBL PK, I mean, you clearly saw it, right? My understanding is any lesion can perf, right? There are some lesions, you know, which are known to perf, calcified, eccentric lesions, osteal lesions, CTOs, when they're calcified, they can perf.
But I think that you should first start by saying that those lesions shouldn't be done in the OBL. Would you agree with that, or you think that's too bold a statement?
I mean, I do it, so I cannot say that it's too bold. I think things can be done in OBL. I think you have to understand what your skill level is and how much you can actually push yourself to do in OBL. I mean, if you're not like, I mean, if it's PK, he can do anything in OBL he wants.
No.
But if it's me, I would say.
I think it's important though, Karthik, because I think, you know, in all kidding aside, I think, like, you know, I think part of it is we have a great OBL boom, which I think we all love, and I think it's phenomenal for the patients, patient satisfaction, the economy, because obviously it's cheaper to work in an OBL and for the economy as compared to working in the hospital for the economy. But also, I think, you know, and safety. OBLs have proven to be incredibly safe. There's multiple papers published talking about the safety of OBL. But I think the case selection, and I know you gave a nice lecture in our symposium in Link Mount Sinai about this. So that's what I kind of want to.
So the case selection is usually you want to try to avoid doing any kind of iliac vessels in the OBL.
Yeah.
Anything which can cause a perf, right? Or anything which can complicate your issues. In-stent lesions like this should definitely be avoided in OBLs, because not only it's not for perf purposes, but for basically embolization purposes. It's just not safe. You don't want to turn your case into, looks to you like you still have some. And then definitely long segment calcified lesions should be avoided in OBLs because the risk of perf. CTOs, long segment CTOs, if they have calcification, should be avoided. I don't say CTOs should be avoided. I think CTOs can be done safely in the OBL. Even long segment lesions can be done. But every OBL, I think, I personally, in my OBL, I carry covered stents. I carry all sizes of covered stents. I have 5 covered stents in the OBL all the time. It's an expense. I understand it's an expense on your part. Each covered stent is like $6,000 in the OBL, which is worth it. You just have to keep it. You don't know when you can perf your iliacs. You have to have sizes, all of sizes. I have all sizes, starting from. I have a covered stent starting for the tibials, going down to the covered stents going until the iliacs. All sizes, long length OBLs or covered stents. You can clearly see, I mean, this happened in this long segment, but if you have a short segment ISR, this can happen in any ISR. So that's what I do in my OBL. I don't know what you think about it, Vishal and PK.
Vishal, what do you do at St. Luke's now? What are some of the things that you want there?
No, I guess it's exactly the strategy is to try to make sure in case of complications like this that you really have a covered stent. So you should have all the sizes, the dimensions, especially when you're doing iliacs. You should always have a covered stent. And then of course you need to know what your covered stent goes through. If let's say you're getting pedal accesses and all that stuff, you have to have the sheet size to remember that you might have to upgrade it if you're not on the correct size. So that's one of the other things I'm always cognizant of is when I'm doing an intervention is to make sure my covered stent goes to the sheet size I'm using, because if, let's say, we're not using the appropriate size, then we might be in more trouble, and now you have to exchange the whole system, which can delay the whole process. So that's one additional factor you obviously.
PK, I think it's a good point you raised, and Vishal said the same thing. covered stents, because of the growing popularity of OBLs. I think what people do is they think just get one size of covered stent or two sizes of covered stents and do it. But the question is you have to get every single size for every single vessel. You have to anticipate your perf in any vessel. So you have to get a tibial size, you have to get a popliteal size, an SFA size, and iliac size. I think that's what makes you,
That's pretty good, right?
Yeah, let me check.
PK, would you think you would have taken a longer stent just to cover that area where we
No,
had?
I really don't want to. I think this is good right here. I think we're good. We're perfect. So we're just going to deploy it here. Okay, give me a 6015 Viatrack stat.
615 Viatrack.
Look it up. So I think what we're going to do is just balloon this up and open quick, guys.
Mm.
So, and then once we balloon this, I think the perforation would go away. So Vishal and I took great care not to involve the collateral proximally.
Right.
And I think I agree with you in having shorter stents, Karthik, but I got to tell you something. I think like in anything, right, the patient, you need to have all different flavors of these stents. I think it's reasonable to have a 75 and a 150 rather than go just with the 250s.
Right.
Just because I think that your perforations are not generally the entire length of the SFA. They tend to be more focal, and it's important to cover the proximal edge and the distal edge of the perforation.
Right.
So in this particular case, obviously, restart the Max, please. In this particular case, I think it's reasonable what we did. We went with a 75. We covered a little distal, a little proximal, and now we're just going to balloon it with a 6 to really expand the coverage stent up against the vessel to tampen out the perforation.
Agreed.
But it's important to get a proximal seal and a distal seal. Okay.
I usually limit my covered stent lengths to
12?
about 100 pk.
Okay, down.
Because usually you don't perf at multiple spots. You probably perf at one spot. So as long as you have any covered stent length of about 100, you'll be able to get a good
12.
seal.
Okay, down. Most important is the distal and the proximal seal.
That's right.
Go up here. Because you can have proximal leak and a distal leak. Okay, so this is where you want to really open it up here.
Right.
Down. And I just want to go forward a little bit right here. Go up not really high. Because now here we have a proximal seal, and now we're going to go get this distal spot here, 12, 14. Down. And then over here. Nice thing about a covered stent is it's going to allow us down. The patient's going to have a lot of flexibility in this particular area right here. And I think it's going to really allow for her to do well in the long run. Down. Okay. Okay, let's take a quick picture. I just want to walk.
Pick any reason you took a Viatrack balloon?
I just wanted to get down there without an issue.
Okay.
Especially with the covered stent and all that.
Okay.
I mean, obviously, not being in an OBL allows me the ability, at least in the inpatient setting,
That's right.
to be able to be more aggressive with my choice of, devices. So collateral is good, lesion is concluded. Now I need to take care of the distal. So now give me a 50150 impact SFA balloon. Let's check an ACT stat, guys.
So you're going to balloon the whole proximal popliteal segment also, PK?
I'm just going to
The
take a
P1
look
segment?
at the outflow. I'm not going to go extend this too distally. I just want to see what's going on in this area with my. See, it's pretty good. So I'm just going to go with a 5.0 up to the filter and leave the rest.
Right.
What size is that? 150 is too long. Give me
You can probably take a 60 or 60
no,
is
probably
okay.
a 120. 120 is good.
Because it's a covered stent, right? So it's not going to add any benefit in that zone.
Yeah,
anyways.
but I mean, I think I'm going to try to push the filter a little bit with my stent
Okay.
and see whether I can get this a little lower than that.
Yeah. Doesn't look like the filter is full.
It's definitely not full.
Yeah.
So now we're going to go DCB this.
120.
So that's the biggest advantage, PK, as you said, right? It's not about doing safety, of course, is a point in OBLs, but the amount of equipment you have to do these kind of complex cases in OBLs is like when you're in the hospital, you don't have to be, again, tied up with the amount of equipment you have to use. If you're in OBL, then you're limited with the amount of equipment you have.
Well, yeah, I think it's a very valid point. I think that's what I meant by case selection. I think that obviously the cases that you select have to reflect what you can do safely in the OBL within the
Right.
constraints of your OBL.
Right.
You know, I think everybody wants to be busy, wants to do cases, which is wonderful. And, you know, as you know very well, I mean, here we always encourage our colleagues in the community to do as many cases as they can. But, I mean, truth of the matter is, as you know very well, it's a bottom line thing here is that, and that's not a good thing, that's all right. It's just a stenosed area. So we're going to have to go up to here. So, which is kind of what Vishal and I were thinking about in the beginning anyway. That's a little stenosed area. So you can see why I know that is because the filter reopened here. So that's kind of the reason why we wanted to balloon that area. So you can see here we're doing an impact balloon at this stage. Just going to leave it up. There you go. So 5.0 is very properly sized because the popliteal clearly is a 5.0. What level is that? Go to 8. What's nominal, guys? 8.
The
And the other
expansion-
thing also, Karthik, in the OBL setting, if you did this case, you wouldn't use a drug-coated therapy because, again,
I would
OBL
not.
is not.
That's
being
why I
used-
said
is
you
not
cannot
being
use long
reimbursed.
segment in-stent occlusions. You can use a short segment. I mean, I use DCB in the OBL, right? So
Well, again, I think an N of 1 is irrelevant to the conversation.
That's right.
Because I think, truthfully, if you think about it, you know, I know you're doing what you can, but you're also a lot busier than most of the other OBL operators. So I think that obviously their cost basis is going to be a little different than
Right.
yours. So I think that at this stage, I think we need to just go ahead and I think these kind of complex cases, it's probably very safe to say that let's keep these inside the arena
Absolutely.
of the
Absolutely, PK.
inpatient setting.
I think I think that's why when you scan the patient with ultrasound, it's important to know what you're dealing with upfront itself, so that you don't just go in, do a diagnostic and find something and then just come out. You know, it's like if you know that you're dealing with a complex lesion based on the ultrasound or a long segment in-stent restenosis, if it's like 30, 40, 50 in-stent restenosis, it's fine. But
So I want to be a little provocative here. So you've got all this data suggesting that you want to do DCB. Starting in January, DCBs are not going to be reimbursed. How does that affect DCB in the U.S. market if there is no reimbursement associated with DCB?
so I use it on OBL. I don't get reimbursed. So I don't think it's going to change any of my mentality towards DCB. If the therapy is important, the therapy is important. If it takes a little more out of the case cost, you have to give that benefit to the patient. No, PK?
Well, I don't know. I mean, Vishal, any thoughts?
Well, I guess, yeah, I mean,
putting on your administrative hat now?
I guess, yeah, you know, you're right. It's a big issue. I mean, cost is what, it's always about the cost analysis which any hospital administration would want to do and see what's beneficial, what, of course, patient safety first, but at the end of the day, it's all the cost that drives, unfortunately or fortunately, our decision making of what we can, what's available, what's not available. So it's the same reason why we don't use drug-coated technology in the coronary in US while we use it in Europe. It's just because of the viability of doing trials and all that stuff. So I think eventually it will affect, it all depends how busy your lab is. Like you said, if you're a lot busy, then you probably have a little bit more buffer, or if you're an economically viable hospital. But if you're one of those community hospitals who really run by the thread and are dependent on some kind of federal or local state funding, then it becomes a big issue because you have to justify why you're using one thing, and it probably might become more restricted or more narrowed down to a specific indication than using DCBs in this case, where you use it almost in every case. So I guess it's all, eventually it is going to go down to the economics, and that's where the healthcare is going to.
PK, you trained him very well. He spoke like a true politician.
Well, you know, I think he's absolutely right. I think he's absolutely right. I think that Vishal hit it on the head. I mean, we all know that DCBs work. We all know that DCBs are very effective in treating. But unfortunately, there is no head-to-head data with DCB against anything other than balloon. So if you look at drug-coated technology, you are able to use a Zilver PTX or an Illuvia, which is, I'm sure, going to come out soon with reimbursement. So I think that you know, the Medtronics and the Spectranetics or the Philips and the Bards of the world really need to be concerned about this, just because I think that this is going to have an effect. You know, without any head-to-head data suggesting that drug-coated balloon is better than drug-coated stent, or that you know, drug-coated balloon is even better than bare metal stenting. We don't even have that data at this stage. I think it's a stretch, I think, at this stage to say that people are going to just or normally use drug-coated balloons. There are philosophical reasons to do it. My worry is that it's going to go from a primary therapy to a treatment of failure of therapy. So I think you're going to have other types of therapy first offered to the patient, and as we all know, there's going to be there are disadvantages to stenting of any sort. I mean, if you could, dealing with in-stent is a different animal versus dealing with balloon angioplasty restenosis. So I think, unfortunately, the powers that be at CMS don't seem to understand what we feel as clinicians. Liz, she's moving. Can you find out if she's okay? I think one of the things for me to worry about is what's going to happen to this therapy, and I'm very, very, very concerned about it.
DCB is probably, DCB has been no doubtedly a revolution in our therapy, in endovascular world, right? Endovascular therapy, it's like taking it out of the market or not reimbursing it is like a,
Thank you.
I feel like it's almost like a disservice to the patient. What do you feel, PK?
That's exactly what I feel. I think the therapy is going to take a big hit. I think the therapy is going to take a huge hit. Because, if you want to give drug to your patient, you have 5-year data with Zilver PTX, show me with the distal wires, showing that Zilver PTX works really well at 5 years. So, right. Fracture rate of Zilver PTX after year 3 remains at 1.9%. Doesn't go any worse than that. So to me, I think there's a lot to worry about in this situation. Right. I'm a big believer in leaving nothing behind, but
right.
Do I have data to suggest leaving nothing behind is better than leaving something behind? Intuitively, you could argue and say yes, but I don't think there is data. And I think the problem is it's the marketing machines of Medtronic and the Bards and all them out there who are not addressing the problem that may be, which is there a head-to-head therapy? You have to applaud the coronary literature. Coronary literature actually went through every single part of it, and part of it is that the physicians demanded to know what's better than the other, and we're not doing that as a community. And I think we need to demand better data, more head-to-head data, comparing the technologies that are available out there. So it's very, very important. Our endpoints with claudication are not life-threatening endpoints like MI, stent thrombosis. Our endpoints with claudication are restenosis and more cost to the system. So if you don't have head-to-head data saying that one therapy is better than the other, it really leaves it up to the realm of reimbursement to say, hey, I'm getting reimbursed to do this. Classic example, atherectomy in the OBL as compared to atherectomy in the inpatient. If you look at my practice, I'm probably 90% atherectomy in the inpatient. So if I open an OBL, I'll be 90% atherectomy in the OBL. If you look at guys out there who don't do atherectomy in the inpatient and are doing it in the OBL, you got to ask about, hey, what's their motivation? It's reimbursement. So I think that it's a very, very thin line that we're skating, and I think it's important that we demand some data based on different therapies, either of industry, either of individual centers. I think centers like ours, NYU, other great centers like Columbia University, and all over the country. I just don't want to talk about New York. Can easily come together and do a multi-center non-sponsored trial within our own areas of treatment, and then try to come up with a publication that at least has some amount of credibility in that it's multi-center, in that we may necessarily not have a core lab, but we have very well-reputed ultrasound labs and so on and so forth in order to go ahead and find out what's a better therapy. I know myself, I've spoken to Sahil Parikh. I'm going to speak to Anwar, Dr. Babayev in NYU. And, we have to get the surgical teams involved with Dr. Ferries, Dr. McKinsey in St. Luke's, as well as, the surgeons, our colleagues in NYU, Dr. Neil Kane and his group, as well as Dr. Bajakian and all of her colleagues in Columbia. And I think we should try to do something like this to really look at what therapy may be better than the other.
It's very, very inspiring, PK.
All right, so we're going to go ahead now. And
so one more DCB?
Yeah,
I think we're going to. Yeah, we have to do one more DCB.
Using a 6.0 DCB speaker?
Yeah, we're using 6.0 here.
So 6.0 AD?
Yeah.
So it's been about an hour and let's see, 15 minutes since you were late, Karthik. So Vishal and I have done a pretty good job here catching you up to this case.
You know, I think the audience already knows that that I was not informed. I think it was very clear
Show me.
that I was not informed, and also I was giving a lecture for the fellows just to make sure that, you know, I was doing some very important work. I was doing some educational work. So even though you and Vishal were like chilling out, having a coffee, I was giving a lecture. I woke up at 5:30 in the morning and I gave a lecture to the fellows. So
we do have the word, my friend. So we're now. This is going to bring up an interesting question here. If you look at the ostium, guys, the issue is, you know, let's go a little lateral, Vishal bhai. What we want to do is we're going to get the balloon out of the guide, and we're going to figure out how far up do we treat this.
Yep. You might have to go just a little, probably a centimeter above the
Give
stent.
a little dye here.
Yeah. It's too much into the
there's
common.
a lot of plaque there.
Yeah,
That's kind of
it's too much into the common
so we're
femoral.
going to keep coming down a little bit here, maybe right there.
Yeah, that's probably
little dye here.
perfect. That's enough.
Yeah, I think that's reasonable.
Because the ostium of the profunda has some plaque shift already, PK.
Yeah, that's my worry, Karthik. Yep.
Yeah.
So we'll give it a little drug here. And again, we're going to go up with our timer. Our ACT, even though we turned everything off, we're on Angiomax. It came up at 300, so we're well covered.
Yeah,
with,
that expansion bothers me, no, more towards the profunda than towards the.
No question. Keep going up. Go to 8.
Yeah, right.
So we're going to go to 9, 10. 10. That's good. Okay, we're going to leave it at 10 here for 3 minutes, and then we're going to take everything out and take a picture and see how it looks.
You think the stent has covered the ostium very well?
I don't know. I don't think it has covered the ostium at all, actually, because part of the reason you can see one part of it is kind of hanging in the breeze and the other part of it is in the ostium. So I'm not certain on how the stent is. IVUS could help us, but I think at this stage, I don't think I want to stent this any further.
Yeah.
I think we've done if we get away with a nice, you know, patent ostium without any flow limiting dissection, I think we should be okay. So again, part of the drug coated balloons, as you guys know, is waiting for everything to elute. It's about a 3-minute elution time. Liz, I'm going to need some nipride. So I'm going to give some nipride because I'm sure we've got some spasm distally with everything that's happening.
You want to take it out regularly? You want to
I think let's take a picture and we decide, right? Should be okay, I hope. Yeah, I think Vishal makes a good point, is whether we remove the filter under suction or just take it out regularly.
So I think the amount of debris is much less in the filter. So I think taking it out regularly, we have already moved the filter. So I think at this point of time, it really doesn't matter how you take the filter out, right?
Yep. And you know, we haven't taken a picture post DCB distally. We don't know what's happening distally right now. Do we have a flow limiting dissection distally? You know, we have no idea at this stage. I mean, we're just treating with drug and deciding.
Okay, just so that now we talked about DCBs, right? So you talked about flow limiting dissections. So DCB dissections, how would you take them? I know if it's flow limiting, you definitely have to, you probably go ahead and stent it. But let's say they're not flow limiting and there is a linear dissection, long segment. What would you still stent it or leave it? What is your thoughts, PK and Vishal?
I don't know, Vishal, you want to take that first?
I mean, with DCBs, if it's not flow limiting, I usually let it go and just let it heal most of the time.
Even if it doesn't matter how long of a dissection it is.
That's a good point. Yeah, most of the time, like I said, if it's non-flow limiting, it looks okay. I'll just leave it and just follow it up by ultrasound. But if it's a spiral dissection or it's a flow limiting or like at the distal edge of the stent or something, then of course I want to tack it up and make sure we have good flow. So that's what I would do. I don't know what PK would say.
PK, what do you think?
I think we don't know the mechanism of DCB failure. I think if you have a flow limitation with the collapse of the vessel, then I think it's probably okay to say, you know, let's stent it. But if you don't have that, then the answer is the true answer is I don't know. I mean, I think again we're going back to our anecdotal ideas, which I think are very, very valid based on experience. But I think, I mean, can you develop a therapy based on the anecdotal evidence? And my answer is no, you cannot. So I think that, you know, the answer is we don't know. I think we need to figure out, you know, what the right thing to do is. Give me some nipride. What the right thing to do is by analyzing DCB failures. I've requested Medtronic probably for the last, I don't know, year and a half to 2 years about this, and asking to look at their data. And you know, they're working on it with me at this time to actually get that done. So I think hopefully if we create a team of people to look at the data, and then do it, I think then that makes sense. You know. I think that's the stage here. What's going on?
Now.
Oh, sorry. Excellent. Good.
All right, let's say this popliteal, I'm just throwing out because, I mean, I see it all the time in OBLs when you have these. Like, you know, let's say if this popliteal has some dissection, what would you do, PK?
What's that?
If this popliteal has a non-flow limiting dissection, would you leave it?
I don't know. Let's take a look at how it looks. Ready?
Hold on. Oh, you want cap? Yes. Right.
No, I would.
Let me fill it up. Yeah.
All right, let's just do DSA first.
You want to do DSA
Yeah.
first? Sure.
I mean, just to see it.
Fine.
Ready?
Ready when you are.
Yeah, this is good. So, and to answer your question, the popliteal has a dissection that, in my opinion, is flow limiting.
Okay.
Just fistula.
Just fistula. Yeah, that is a dissection right there. See how the main lumen is on.
Yep. Inject.
Mm-hmm. Also looks good. 80 is also coming out.
Mm-hmm.
I would personally leave it, PK. I would personally leave it.
I will leave it.
You would leave it?
I would personally leave it at this point of time. I mean, you can always watch it on sonogram. You closely, as long as you closely watch your patient, I think this can be watched over. You can always come back and revisit it.
Dorado.
So give me a 6020 Dorado.
Do you want to look at the ostium, PK?
I will, but yeah,
So
that's a
the
good idea.
filter
We
out.
can look at it now, but I think we already, the flow in the profunda is terrible.
The pro in the profunda is going down. That's what concerns me.
Yeah.
So the plaque shift is what concerns me more.
I don't necessarily
they're-
think it's plaque shift. I think you just have you just have more preferential flow down the SFA.
The
Yeah,
ostium doesn't look damaged, so it's good. I think
it
we
doesn't
just
look
leave
that
it.
damaged. We'll do an IVUS of it. Let's see. Well, let's take care of the SFA first here. Ready?
Hold on. Go.
Looks like there's a little goober there.
Yeah.
There's something there. So give me a 5020 DCB here.
You're going to DCB the ostium of that.
I'm going to have to here. But I think what I'm going to do is take care of the SFA first. Give me the 60. Give me a roadmap here.
Yeah.
You want to stay online, PK, or?
Yeah.
Okay.
I think well, that's not it. Is that it?
That's it.
Yeah, that's the spot.
That's the spot. It doesn't look that bad when you mag up, huh?
Yeah.
I think we'll stay online for another 5 minutes because I think it's important to see what we decide to do with the profunda as well as with the distal popliteal. As you can see, these cases can take what, an hour and a half now.
Okay.
So we're an hour and a half into the case.
You're
we're almost done.
You have something in your mind about the popliteal, or?
I don't know. I mean, I'm thinking that let's take the filter out and then decide kind of thing, you know?
Vishal, what do you think?
No, I'm like you rightly said, I'm a little bit concerned. There's probably a little bit of goober right there, so I would just.
No, you're talking about the popliteal.
Oh, I thought it's a profunda. Now, popliteal, I would leave it.
Well, I don't know, man. With that covered stent, I don't know if you'd leave it. I mean, with that covered stent, it's a big deal.
I think you created a lot of flow into the SFA, right, PK? So I
know,
think
but
if you
just
leave
worry
it,
you, if you have a flap like that, the question is which side of the flap is going to close, and you know, if the flap is one side or the other,
right?
You know, if it flips over into the non-lumen side, then you're going to thrombose the entire SFA again. I think in this case, it's worthwhile to just drop a short, you know, Zilver PTX or something like that, just a short stent and be done with it.
Zillow
that's-
PTX, you think even though
popular.
you had a DCB done?
Well, that's another good question. I mean, there's no data on for DCDS on DES. You could argue that you could put a short EV3 protege, like a 60 EV3 stent.
Why don't
here.
you put a superior
You get it?
PK?
And I don't want to necessarily use the superior here. I mean, I think that you've already got so many issues going on with the size mismatch. I think you have to worry about if you have a 5.5 or a 5.0 or a 4.5. I'd much rather just go with a regular stent. I've already given drug. I think the chances of fracture at that particular point
Is much less.
are low, and
yeah.
I think I'm not too worried about it. Down here, okay. So I'm going to take care of the pop first before I worry about my profunda. So right now I'm just going to walk this balloon back, and then
The ostium looks pretty clean for the SFA, so
Yeah.
that's a good thing.
yeah.
Me
So
and,
you're
command wire.
planning to drop a stent, or you're trying to take the filter out first?
Well,
we're
I want to take another picture here. DSA.
Hold on. Yeah, DSA.
Not yet, Liz.
Lights are off, guys.
Much
Nice.
better.
Vishal, I think you stepped on the lights.
Yeah, no, I'm going to turn it back
And the
on.
profunda flow is.
Profunda flow is looking better already. So sometimes you just, enemy of good is better here. Let's take a shot
So
here.
I think
again.
if you leave it, just give some more nitro and verapamo, some vasodilators.
Yeah, why don't you give me a 6060 Zilver here? Let me see if we go from there up. Vishal is okay, right? Yeah,
Yeah.
60 should cover it. Give me a 6060 Zilver.
Because if you're doing,
Roadmap.
why don't you just cover the segment until the
Roadmap.
stent?
Yeah, that's what I'm doing. It's a 60.
80.
I think it is 80.
It looks like it's more than 60, no?
Yeah, 80.
No, from there to there. Okay, give me
No,
an 80. Give me an 80. 6080.
6080 silver.
Just to be enough.
I think 60 would have been just enough, but 80 is
Okay,
probably
we want
better.
we still
I
have
think
enough.
80 is better. What's 20 millimeters?
Nothing, same price.
Good point. 6080.
Vishal, I think we are right. It's 80. 60 only going short. I don't want to agree with PK. I think we agree with PK too much.
I think it's the same price, so I would probably take longer.
I agree with that.
See? All right, let's go.
Profunda is saying don't touch PK.
Yeah,
I don't know. Let me take a look. Let me take a look after this.
So I think anything you do in Profunda is going to move back into the SFA.
80.
So
Yeah, I think you could see on the DSA shot last one, it was almost coming up next to the SFA, so I think you're right.
Makes sense.
because it's
Just
a
leave
it's a
it.
bifurcation thing. You move one,
Yeah, it'll come back to the
it's
other.
going to go back into the SFA. It has no other way to go. So I would prefer it to leave it, recanalize itself, form itself, endothelialize itself, and then
It's all very good points.
But PK also has already something in his mind. Vishal, I can read it.
Now, this time I'm sure he's going to agree. Or I'm hoping that he's going to agree.
As usual, he never agrees, but that's fine. I just want the audience to know that PK never agrees with me and Vishal. So
What's the thing? Real?
Yeah. Oh, the 80.
It's a little too long, but that's another story. But
I think it's perfect, but it's okay.
Yeah.
give us that power cross, Balloon 60 power cross. Or whatever, the Biotrack is fine.
It's too small.
Wow, filter. It's okay. It's in the stand.
That's okay. Vishal wants to demonstrate everything, so it is okay.
All right, give me the balloon.
Yeah. I think we should just take the filter out.
So as you guys know, that it's when you do in-stent, you can expect anything. Just to summarize, as PK is doing, we had a totally occluded in-stent SFA stenosis, CTO. We were trying to cross. There were a couple of options we had. We had an option of going antegrade or getting a direct stent access. As PK said, direct stent access should be reserved for things as we discussed, just because of the problem with the compression, especially if there is a flow in the stent. And then we try to cross from above. We cross from above. We again support issues as we discussed with the balloons you use and everything. And if it's based on the vessel runoff, usually if it's an in-stent CTO, you might definitely want to put a filter because of the combination of fibrosis and stenosis, atherosclerotic tissue, and some kind of chronic clot burden. So we used a laser based on our consensus. We talked about the data. Then we opened up the vessel and we came across a perf which we didn't expect, and that's good as usual.
Down.
As everybody knows, PK demonstrates everything online, and
Down.
you get a complete review of all the complications you can have in our course, and then we handled it very clearly. We DCP'd the whole SFA, and we have some I wouldn't say flow limiting, but concern for PK is because of the outflow of that covered stent is dependent on the popliteal. That's the reason this vessel has been, this P1 segment has been stented. And then you can clearly see, voila, it's a beautiful, beautiful result.
All right, let's take the filter out.
Yep, we're going to take the filter out now and then turn our attention to the profunda.
And then we had some kind of plaque shift or some kind of a debris in the profunda ostium, which reduced the flow of the profunda. So we're going to look at it and see what we're going to find now.
So I think it's as good a result as you can need. You've got drug there, matter of fact, double drug there. So hopefully this is not going to restenose. It's at the outflow of the of our covered stent. So which again is an area which is always of concern among users of covered stents. Users of covered stents. So I think that the outflow here is pretty good here. We've got a robust dominant perineal that we talked about earlier on, and the dominant perineal obviously is going to the dominant perineal obviously is going to go ahead and be able to protect us from any issues. So we've got the thing out now. We're just going to check our outflow. Flush forward, guys.
So as PK is doing, you might want to bleed some. When you do long cases like this, as soon as you take the filter out, bleed at least like 10 cc's of blood or 20 cc's of blood, so you clear off all your debris. Check your outflow.
Ready?
Yeah.
Make sure outflow is okay, that you didn't embolize anything, because it's a one vessel runoff. And clearly it's beautiful result. So
It's excellent.
So always check the flow down to the level of the foot. Make sure you have a good flow down to the level of the foot, because that's what you're more concerned about.
Inject.
So we had a profunda with giving some collaterals to the dorsalis pedis and some collaterals to the posterior tibial.
Take another picture.
And you can clearly see you have it, but I think it's the dye is just light. Vishal was too stingy. And
Good. So everything is right there.
everything
Beautiful.
is right there.
AT
You have the
comes in,
collaterals
PT
to the
comes in.
HE.
Now we just got to look at the profunda very quickly, and then we'll be done.
PK, again, I think I asked you before also, would you ever come back to the AT to give more outflow to that vessel because of the covered stent?
We might have to in this case, especially with the profunda
Okay.
issues. Inject.
Yeah.
So that's clearly looks like it's a plaque shift or some kind of a debris. I mean, it's a debris, it's a plaque debris. So you have a very good flow into the SFA, right, PK? So would you still want to balloon it? I would just leave it, PK.
One of the things we could do here is, let me do something. So one of the tricks that I want everybody out there to see is that the profunda basically is the largest supply to the thigh, right? So give me an 035 wire, guys. So what you want to do is pull this catheter above the
Level of the internal iliac
and then inject.
Inject.
Give me a supercore.
And see if the internal
and then
iliac
see
gives
whether
collaterals
there's
to the
supply
profunda.
into the profunda via collaterals. If there's no supply to the distal profunda via collaterals, then I'm going to treat this. If I see the distal profunda light up from my injection above the internal iliac, I'll probably leave this and I'd follow her closely, see how she does. Either way, I'm gonna put her on antithrombotics here, and so I think part of that is just go ahead and see, you know, how she does. You know, let me see here. Let me walk this. Show me higher. So let's do it from here. Now show me the profunda now. Low mag.
Mag out, yeah.
And then let's come a little more lateral. You ready?
Ready. Injecting.
No, it's too early.
Oh, let it come. The collateral.
There's no collaterals. There it is. See, now you've seen the distal profunda fill. The question is from where, right? That's the only issue.
Are you sure you're above the level of the internal ilia?
I think so, because it did fill. Give me a little dye here. See, we're a little above. It can come even a little higher here. Okay.
You can take a picture there. PK.
Yeah.
That's fine. Ready, inject when I tell you.
Yeah.
Inject.
I think you're getting it. You can see it right on the lateral side of the 10.
Not very happy. Because I can tell you right now, most of it is really coming through the through the SFA. And
So you see at the level of 5, PK, you already see it before the SFA fills. You can see your collaterals coming at the level of number 5. At the beginning of the picture.
you know
Right.
what? Give me a 5.0 DCB, mag up, and give me a vertib catheter here, guys. That's fine. Give me a vertib catheter. Yeah, I don't think you should leave this profunda.
Okay.
I think a 5.0 DCB, a very gentle balloon inflation for 3 minutes. Patient will do well. Yeah, you
Yeah.
can open it.
What do you have? Command or anything?
You're only concerned because if the SFA closes, the profunda is not a backup. That's what it is.
Well, I just think that the collateralization is very poor. We have a covered stent distally. I think in this particular case, I just don't want this profunda to close off. I think the flow is not good. She's fully anticoagulated at this stage right now. Watch yourself.
Right.
I think at this stage is like, you know, something that clearly you want to watch carefully. Okay.
Here,
No, just I just
Yeah.
don't want it to go forward.
I'm going to keep it right
Okay, a little diarrhea, Michelle.
there. 1 second. Okay, leave it.
Yeah, see right there. Okay, a little Dinah.
No. That's
I know. Give me a little roadmap. There it is.
Yeah.
That's good. Yep. Now give me the DCB. So let's take the sheet then. Show me the sheet. Red. Okay, good. What's going on here? Oh, because I'm lateral? Yeah. Okay, good.
So you're using a 5030 DCB.
5040, yeah, the shortest DCB. DCB? Yeah, I think this is better to be taken care of on the table than afterwards.
Okay.
I just have a feeling about this. Just the flow is not that good. Very thrombotic looking, very plaquey looking. I don't want this to, you know, get
Okay.
crazy. I just want to gingerly just balloon this and be done with it.
Gingerly blue.
PP, guys.
So PK, just so that you
Little dot.
Vishal is inflating.
I'm sorry,
Vishal, gingerly, you want to ask him what gingerly means. So
Go up right here.
Yeah, 1 second. Let him finish this, then yeah, we'll figure it out.
Just like 2.
Yeah. You want to cause it to move to the other side.
3. That's it. 4, 5, 6, 7, 8.
so what's the
Now
stent?
let's take a DSA shot.
Yes, sir.
Inject. Okay, good. That looks fine. Let's see. So I think this case, like you were saying, Karthik, illustrates a lot of things in this particular patient. I think you talk about all the complex decision making, all the things that can happen when you're dealing with an osteal SFA occlusion. From process of actually doing the intervention all the way down to actually making the complex decision of when to stent, when to use a covered stent, and when to use when to treat the profunda. I mean, honestly, this is probably one of the few times in my career where I've actually done this. But that profunda did not look good, and the collateralization of the internal was not phenomenal. You could have argued leave it, see how it does. But I think when you're here, you can put a small balloon, leave it up for 3 minutes, and then see how it does. I think you're going to be okay, especially with drug-coated technology. I would much rather lose my SFA than lose my profunda. And I think that's kind of the take-home point here in this situation. If I had to choose between all the hard work we did with the SFA and now with the profunda, I firmly believe that treating the profunda is the right thing to do in this situation. So hopefully I'm proven right. After this balloon goes down, we'll take a look and then we'll decide.
Would you would have aspirated it before by using?
It looked like there was a little bit of plaque shift. It didn't look so much of a clot. I think we were very good in terms of our anticoagulation. Our ACT was never below 300. We didn't have any debris in our stent. We didn't have any distal embolization. So I think all those positives go towards not worrying about a thrombotic situation here. But I think that's a very good point that you want to watch out for the etiology of what's causing this. And I think Karthik hit the nail on the head. He didn't like the way that balloon expanded, and I think that was part of it. But here, this is one of the challenges of osteal SFA intervention, just like in the coronaries when you're dealing with a LAD, circumflex bifurcation, or a left main LAD ostium. It's the same situation, and you have to pick your poison, And I think we're going to be okay. Even if we plaque shift a little to the SFA, I'm actually going to leave that and just move forward, because I think that with the drug and the positive remodeling that you're going to expect from that, I think you should be okay. So we're going to go to 3 minutes. We're at 2 minutes 15 seconds. So I think for the audience, if this profunda shot looks good, and regardless, we're probably going to stop. It's been about an hour and 45 minutes that we've been in this case, one of our longest case presentations. But I think an incredibly challenging case with a lot of clinical decision-making challenges. So when Vishal comes down with his balloon, we'll take a quick picture and then we'll decide. All right, balloon's down. All right, let's walk it out. You ready, guys?
Ready.
All right, that's good.
Yeah, there is some validity to being a little older, a little bit wiser, a little bit better looking. There's a lot of things that come into play here that I don't want to talk about in front of our audience.
Wiser is fine, gray is okay. Good looking is something we have to discuss about, but again, it's okay.
Again, I thank all of you for your attention. Karthik, great job, and Vishal and I are buying you a tie. And we will see you next month. Thanks, guys.
Thank you so much.
Thank you.
Nice job.
All right, thank you guys for joining us. I hope you guys enjoyed the case. I think PK has demonstrated it phenomenally, as he always does, along with his team, Vishal and Sandeep, and all his nurses and techs. So we look forward to seeing you again live on September 27th for our next live case. Any other cases we have previously, and this case will be uploaded in a week to the archives. And if you guys have any questions, you guys can email us and we'll be more than happy to answer your questions. We'll see you guys again next month. Thank you.